All right. Good evening, everyone. Welcome to Taylor Tuesday. Thanks for joining us this evening. We've got a great talk ahead of us with Dr. Lehrman, who I'm sure all of you are very familiar with. I'm Michelle Butterworth, straight out of rural Kingstree, South Carolina. Been involved with Taylor Medical since the start, and as one of their directors, and very involved with just promoting it forward and seeing what we can do for our colleagues. I'm here with Dr. Andrew Schneider, also one of our moderators this evening. Andrew?
I'm also a shareholder. I've been involved with Taylor since the beginning, and I've seen a lot of great savings from being a Taylor member, and I highly recommend it, and we'll discuss that in a minute.
Okay. So tonight's webinar, if you'd like to find it on our website, you can certainly visit that at www.taylormedical.com. Also, there is a whole listing of our previous webinars. If you'd like to look at those, you can certainly look up where the arrow is there in the right-hand corner to also get you started with that. As you know, we've got a bi-monthly series, so it's usually the first and third Tuesday of every month. So I hope you join us again for our future talks.
If you're not familiar with Taylor Medical, or this is your first Taylor Tuesday, Taylor Medical is a GPO, a group purchasing organization. And what we do is leverage the buying power of our members, and we negotiate discounts with key vendors in our industry, which ultimately saves us money on products, on supplies, and capital equipment. Membership is free, and not only is membership free, that from qualifying purchases, you'll get a check for 1% on all those purchases. So what I recommend you do is print out your orders for the last the last 3 months of your orders. Get them in an Excel spreadsheet. Send them over to Taylor Medical at admin@taylormedical.com. If you're going to the National next week, it's a great time to print it out and bring it with you, because I'm sure they'll be there. And I think you're going to realize the same thing that I've realized for my practice, some very considerable savings. So I would like to take this opportunity to introduce our speaker, Dr. Jeff Lehrman. Dr. Lehrman should be a stranger to none of us, between the talks he does in Taylor Medical and the moderating, as well as conferences all over the country. Dr. Lehrman is a certified professional coder. He's a certified professional medical auditor, and he operates a consulting firm and provides guidance regarding coding, compliance, and documentation. He's also a Taylor Medical shareholder. He is going to share with us a talk about coding during the postoperative global period, and I'm going to pass this along to Dr. Lehrman. Thanks so much for joining us.
Thank you, Andrew and Michelle, and welcome to those who are joining us live and those who might be watching after the fact on demand. Oftentimes, when providing coding education, I find that we are talking about things that we cannot do, and rules that we don't like, and things that I might share, things I've seen attempted that were wrong. But tonight is different. Tonight, we get to talk about something that we can, and in many cases should be doing, but instead, oftentimes these services are not appropriately coded for, or not submitted at all. And in many cases, we are providing services that we must, should, and can submit coding for. And if we're not, it's not appropriate coding. And worst of all, we're not submitting claims for services that we can be, which can lead to money left on the table, which is bad. So tonight, we are going to discuss appropriate coding during the postoperative global period. Tonight, we are going to mention some CPT modifiers. And anytime CPT information is shared, codes or modifiers, we must provide the reference that CPT is a registered trademark of the American Medical Association, with all rights reserved by the American Medical Association. And the reference for CPT codes is the current year CPT book. And as we broadcast this live in July of 2022, that reference would be the 2022 CPT professional book. If you're watching this, you probably know that all CPT codes have a global period, either 0 days, 10 days, or 90 days. And during that global period, any services that we provide that are related to the procedure for which the patient is in a global period cannot be separately reported. However, there are exceptions, lots of them, which is what this entire webinar is about. If a patient is in a postoperative global period, there are certain situations where we can submit coding for services that we provide. And the modifiers that we're going to talk about and that are on this slide apply to patients that are in a 10-day global period, just as they apply to patients that are in a 90-day global period. So again, some procedures have a 10-day global period, some procedures have a 90-day global period. I suggest, if you are doing your own coding and making these decisions, you should know which services have a 0, 10, and 90-day global period without guessing, and by using an appropriate current source. I see too many colleagues get into trouble by Googling this, which is not the way to do it, especially now, because in the last 2 years, we've had several really pertinent changes to global periods. Hopefully, if you're watching this, you know that as of January 1, 2021, we had 2 different toe amputation codes move to a 0-day global period. And effective this year, January 1, 2022, we saw 2 very commonly used incision and drainage codes move to a 0-day global period. So be sure you're using an appropriate source to determine how long a global period is and that it is current or being updated live, because these things are changing. If a patient is in a global period, we have these different options for services that we might be able to report using these different modifiers. Take note that for evaluation and management services during a postoperative global period, there's only one modifier. But when providing a procedure during a postoperative global period, there's 3 different modifiers. So much more rigid guidance for evaluation and management services during an evaluation and management period, and more options for procedures. So I'm going to say again, because it's a common question, the rules for E&Ms are different than the rules for procedures during the postoperative global period. So let's do the E&M one first. The 24 modifier, its exact description, copied and pasted from the 2022 CPT book, is on this slide. This is exactly what the 24 modifier represents, and that is an unrelated, it's a really important word in this, and I'll give you a couple examples as to why, an unrelated evaluation and management during the global period. So this is an evaluation and management that is unrelated to the problem for which the patient is in a global period. So it has to be unrelated to that problem. So let's say the patient has a bunionectomy with a first metatarsal osteotomy, like a bunionectomy where we remove the medial eminence and we perform a chevron osteotomy, for example. That has a 90-day global period. And let's say at the 2-week, 4-week, whatever, postoperative visit, the patient says, you know, I've been meaning to mention this for a while. My feet are itchy all the time, and I tried whatever, and it didn't work. And we perform a history of present illness and document all of this, right? How long has it been there? Have you ever had it before? What have you tried? What makes it better? What makes it worse? What we do, document all of that, perform an examination of the area of concern, and we document what we see. Dry, scaly skin, peeling, whatever, right? And we document all of that. Diagnose the patient with tinea pedis, and then manage the problem. And we document that management of describing what it was. I explained to the patient what it is, risks, complications, treatment options, advantages, disadvantages, and we made the decision to treat this with product X. That's an evaluation and management. And that tinea pedis has nothing to do with the bunionectomy surgery for which the patient is in a postoperative global period. That is an unrelated evaluation and management. And we absolutely should document all of that and then report an E&M for that service with a 24 modifier because it was unrelated. Now, that's an example of where we can use it. Unrelated does not equal unexpected or different diagnosis or complication or a real pain in the butt and a hassle. That's not what this says, right? It has to be unrelated. So I'll give another example, one that I find to be incredibly frustrating. Maybe you're a more patient, kinder person than I, and I don't mean to project onto you, but I find this to be frustrating, right? So let's say, and I hope you start to nod your head and that we've all experienced this. Patient is 2 weeks post-op transmetatarsal amputation. It could be any surgery that has a 90-day global period. I just picked one. 2 weeks post-op TMA. Patient takes off their bandages at home, looks at their foot and doesn't like the way it looked, and they think it's red and swollen and hot. And what do they do? What do our people very often do in that situation? They go to the emergency department. And what happens in the emergency department when a patient has a red, warm foot with stitches in it? Admit, right? Most of the time. Right in they go, whether they need it or not. I'm sharing my frustrations. Now the patient gets admitted. We get the call, right? Now it's Sunday night, and we are consulted to go see this patient. And get in the car, drive 25 minutes to get there, walk 10 minutes to find the patient, but they're not in the room because they're in radiology getting an x-ray done. So now we walk down there, and they don't want us to unwrap the bandages there. So, all right, so we've all lived this, right? 3 hours later, we're done, and our note is complete, and we're walking back to the car, and this patient had a mild superficial cellulitis that just requires some antibiotic. And that's the recommendation that we made. No surgeries needed, no IND, they just need some antibiotic. That's an evaluation and management during the postoperative global period, and that is very much related to the problem for which they're in the global period. That is very much related to the transmetatarsal amputation. So I've seen errors of people thinking, well, they have a different diagnosis. That's not what this modifier says, right? Or this was unexpected. This isn't part of the normal postoperative course. That's not what this modifier says. That horrible situation that I just painted is related, and that's just part of being a surgeon. That visit stinks and is no fun. That's just part of the deal. That is related. So I gave an example of unrelated and an example of related. So that's E&M, and that is the only option we have for evaluation and management services during the postoperative global period. Now we'll shift to procedures, where there were 3. So this gets to be, we get a little more wiggle room here and more opportunity to submit coding for the services that we provide when they are procedures. The 79 modifier is really the procedure equivalent of the 24 modifier because this is an unrelated procedure. And it's everything we just said about E&M. Has to be unrelated, not different diagnosis, not unexpected, not a hassle and took a lot of time, an unrelated procedure. So let's give an example. We could take the same 2-week post-op bunionectomy patient that had the tinea pedis. Let's say instead that person had an ingrown toenail that required a partial nail avulsion with a CPT 11730. Totally unrelated. Has nothing to do with that, right? So of course we can perform a local block, remove the medial border, whatever it is, perform the procedure that is represented by CPT 11730, and submit that with the 79 modifier. Take note that the 79 modifier makes no mention of where the procedure is performed. Doesn't matter where we do this, office, hospital, operating room, ED, whatever. Doesn't say where. So 79 unrelated, doesn't matter where we do it. Now, this is where we start to diverge from the E&M guidance, because now we have what we did not have for E&M. We have a modifier for a related procedure during the global period. The word related is on the second line of that slide there. Related procedure during the postoperative global period. So now let's say that TMA patient that had the sutures in, maybe it was so edematous and it looked like there was fluid in there or hematoma or something, needed an IND. Well, that's a related procedure, but there's a catch with this one. The 79 for an unrelated procedure made no mention of where. It didn't matter. The 78 for a related procedure says this must be performed in an operating or procedure room. Has to be performed in an operating or procedure room. So if this person is in our office and we do an IND of that hematoma, no good. How about the hospital story that we told, right? What if we go on Sunday night, we find them, we go to bedside, they're neuropathics and it's fine and we're comfortable with sterility or whatever concerns there might be, and we pop those sutures and perform an incision and drainage right at bedside, can't submit it because it's not in an operating or procedure room. On the other hand, if there was an abscess or whatever the situation was that you thought it warranted a trip to the operating room the next morning, and now we do an incision and drainage in the operating room the next morning, then we can submit that service with a 78 modifier. Now, I think this isn't cool and it's not fair, and I've often been asked, so do you mean I should just wait until the next morning and take them to the OR, even if I could really do it at bedside? Well, no, that's not consistent with the oath that we took to do the best thing for our patients at all times. Decisions, of course, you don't need me to tell you this, but I'm saying it because I've been asked, right? Our decisions should be guided by what's the best thing for the patient. And really, even from a payment perspective, an umbrella that governs all of this, all coding everything, is medical necessity. So if they're going to go to the operating room, of course, that's being a good doctor and being ethical and fulfilling our oath. They should only go if they have to. But from a payment perspective, they should only be there if it was medically necessary to be there, right? The reason to go is not because, well, if I do it there, then I can submit the coding, which I know this audience very likely doesn't need, but I have been asked. So I wanted to comment on that. So related procedure during the global period, operating room or procedure room. Has to be in an operating room or procedure room. Many of us have procedure rooms in our office. So that can work, right? That counts if it's a procedure room, right? And you know what the difference is, right? This is a designated room that is maintained differently. This is not somewhere somebody was getting fungal toenails cut 7 minutes ago. Those that have procedure rooms, that's a separate deal. And many of us do have those in our offices. I meant to say this at the beginning. I'm watching the time. My goal here was to talk for 30 minutes or so, leaving lots of time for Q&A. I think we're on pace. I might go a little over here. We purposely wanted to leave lots of time for Q&A. So please don't be bashful with your questions. We're hoping you'll feel comfortable submitting lots of them. If you look at the toolbar for this service that we use there, you'll see the word chat, and you can click that and free text, type in anything you got. We're leaving 30 minutes for a reason, so please use it. We hope you'll feel comfortable submitting those questions. The 58 modifier is for a staged, planned, related procedure during the global period. So this is staged and planned. This is, we knew this was coming. I expected this to happen. I staged this procedure. So let's again do an example. An example would be maybe patient has gas gangrene of the forefoot, and we do guillotine transmetatarsal amputation because it's gas gangrene and it's gross and it has to be left open. Guillotine amp and it's left open to drain. Well, we know we're going back, right? Or probably going back in a couple days, or maybe it's not gas gangrene. Maybe there's just a lot of pus and it needed to be left open to drain. Or maybe it was a wet gangrene where we needed to get the bad stuff off, let vascular do what needs to be done, then go back and do a more proximal debridement and closure or something, right? If we know there's gonna be more work, those subsequent staged procedures can be submitted using a 58 modifier. 58 modifier says, I knew this was coming. This was part of the plan. I expected this to happen, right? But there's an important element of this, which I find a lot of colleagues miss. And that is, at the time of the original procedure, at the time of the procedure that starts the global period, it is important that we document our intent to perform staged procedures. I like to think of this as planting the seeds for the staged procedures, or maybe better stated, buying the ticket that allows us to then submit that 58 modifier. And that's in our op note, right? So using the guillotine TMA as an example, in the op note for the guillotine TMA, document this was left open because, right, it was gross and it needed to drain and we need demarcation, whatever. Well, you know what the reason is, right? You know why you left it open. This was left open for the following reasons. Therefore, and I'm making this up, it doesn't have to be exactly this, but I think this is a good example. Therefore, I expect that we will have to perform more planned, staged procedures as part of the multiple procedure staged effort to salvage this person's limb, right? You could do the same thing with an open fracture that gets reduced, right? Like not ready for fixation yet for whatever reason. Therefore, I expect that we will need to return in X days as part of the staged multiple procedure effort to appropriately fixate this trauma. Setting the stage, buying the ticket. Then you can use the 58 modifier on those subsequent procedures. And notice I've only given one example of appropriate use of the 58 modifier. There's 3 bullets there, right? So one example is what we just said, stage. And I think I gave 2 good examples of that. Look at the second one though, more extensive than the original. How about this one? How about we do a partial ray amputation, hallux and half of the first metatarsal, and we close it and we document. This looked good, looked like adequate circulation, healthy tissue, primary closure performed. We're not expecting to go back, right? There's no plans or staging here. We're done. But 45 days later, 60 days later, this person's still in a global period. This could totally happen 60 days later, right? It's shot, it's dead, it's necrotic, it's no good, and patient needs a TMA. Well, that wasn't staged. That wasn't part of the plan. However, that TMA is certainly more extensive than the partial first ray amputation. So that's another situation where it's appropriate to use a 58 modifier. You could do the same with fracture care, right? Like we try, how about a closed reduction? Maybe it's a central metatarsal fracture, closed reduction in the office. We think everything's fine. Cast, boot, whatever we do. But 2 weeks later, it's moved. And now we decide we need an ORIF. Well, that wasn't staged. That wasn't planned. But certainly the ORIF is more extensive than the closed reduction, which I should have said has a 90-day global period. That closed reduction has a 90-day global. So that's another example. More extensive. And the final example is maybe some of us provide therapy services, like we're doing something for range of motion following a surgical procedure, maybe RF of the ankle, and 6 weeks later we're doing some kind of range of motion therapy. That would be appropriate use for the 58 modifier also. I hope you'll find an important take home from this is the documentation that, like I said, buys us the ticket, allows us to use the 58 modifier on those subsequent procedures during the postoperative global period. So I often get asked, now that we've covered these modifiers, I often get asked, I did an amputation, it dehisces open 3 weeks later, and I debrided in the office. Can I submit coding for that? Well, probably not, unfortunately. Let's give two different scenarios, right? If we did that amputation and we observed and documented adequate vasculature, good healthy tissues, primary closure performed without any extraneous tension, and this looks good and we're done, then which does happen, right? Then it dehisces open 3 weeks later and we perform a debridement in the office. Let's go back here. That it's not staged, right? We said everything was fine and primary closure was performed. It's not unrelated. It is related. So this is an related procedure, but it's not in the operating or procedure room. So we can't submit that. I agree, not cool, not fair, super frustrating. Those are our rules. Now, on the other hand, what if we have a transmetatarsal amputation and because of tissue quality or tension or whatever reason, the dermatomes of where the vascular disease is, we only close a third of it, leaving a big chunk of it open, and we document the lateral 2/3 of this was left open for the following reasons. I expect that during the next couple of weeks or months, I don't like that as much. I expect that during this postoperative global period, I like that better. This is going to require staged procedures as part of this multiple procedure effort to get this to heal, to salvage this limb. And no rule that says you have to do this. I even dictate, and these procedures may take the form of debridement, skin substitute application, hyperbaric oxygen supervision, skin substitute application, or others, or something like that, right? That's okay. That's totally legitimate. That's all true. So if it's appropriate, and if we thought it might be coming and we documented it, certainly. But what we cannot do, and I've seen this happen, what we cannot do is have that situation where we dictate everything's great, it's perfect, it's clean, it's healthy, it's beautiful, primary closure, and then it pops open 2 weeks later, and then people want to start using the 58 modifier. No good. Doesn't work that way. You can't have both, right? And of course, again, don't have to say this, but just to be thorough, because I've been asked, well, how about, what if on, many of you are giggling, you know what's coming, right? How about on every single amputation I document that it was no good and I'm going to have to perform subsequent? Well, that's not right? Because if it was clean and healthy and primary closure was performed, that's what we have to document. You can't make stuff up. And if you were ever to be reviewed, that would be really easy to figure out, right? If you did 100 amputations and had that same paragraph on all 100 of them, that's going to raise an eyebrow, right? It could happen. You might have 100 consecutive people that primary closure isn't appropriate, but you know what I'm saying, right? We should document what was actually going on. The title of this was Services During the Post-Operative Global Period, but we're going to add a couple of comments on the pre-operative period. Any procedure, I see a lot of colleagues get hit on this because they don't know that the 57 modifier was an option and they're throwing away coding that they should be getting paid for. Any procedure that has a 90-day global period, that global period typically extends to 24 hours before the procedure. This can actually vary based on payer, but for the most part, what I said is true. I'm going to repeat that because I suspect this is new information for some. Any procedure that has a 90-day global period, that global period actually extends to 24 hours prior to the procedure. So the 57 modifier is for a situation where the decision to perform the procedure was made within 24 hours of the procedure. So let's give an example of this one. Let's say we go to the hospital today. We were consulted to see a patient in the hospital today. First time we're seeing them. And we go in and we see them, and it's a big patient has a large abscess that needs I&D tomorrow. Well, that's an evaluation and management today, right? That's a consultation service, which has an E&M code. Today's visit. And we do the whole consult. We schedule them for surgery tomorrow. They get an I&D tomorrow. Well, that incision and drainage may have a 90-day global period. And if it does, that eats today's encounter. However, today's encounter was the one during which we made the decision for surgery. So if you know you're operating tomorrow and today the decision for surgery was made, we can put a 57 modifier on today's evaluation and management. Now, here's a situation where we cannot, and I've seen it, which is why I'm sharing it. I've seen people do this incorrectly. Round the inpatient, let's use the hospital again. Rounding in the hospital, and it's Friday, and we document that maybe the patient had an open amp and it was demarcating and waiting to get cleaned up, and we've been rounding on them for a couple days, right? Now it's Friday, and we go in there and say, looking good, this should be ready for closure on Monday. On Monday, if everything stays the same, we're going to go back, debride more proximally, and perform primary closure, and then you schedule it, right? It's on the OR schedule for Monday because that's not going to happen over the weekend. And then we go in on Saturday and say, everything's good, scheduled for Monday. And then we go in on Sunday. Now, Monday's procedure has a global period, which extends back to Sunday's visit. And if the only thing that happens at Sunday's visit is, yes, we're ready, plan for OR, all patients' questions were answered, consent was signed, NPO, right, whatever we do, that is not making the decision for surgery. Yes, it's work, and yes, it's not fair, and we had to drive there and put in orders and all the other stuff. However, that is not decision for surgery. So I've seen the mistake made where providers think, well, if it's 24 hours before surgery, I can use the 57. That's wrong. We can use the 57 if it's 24 hours before and the decision for surgery was made. There's only a couple questions. So I'm gonna make one other comment on this before we move to the Q&A. Don't be bashful with the questions. We hope that more will be entered. And you don't have to wait till the end. You could type them in now. I'm going to make one other comment on this because we have time. And that is about the pre-op visit. This is another common question. The pre-op visit. Patients, let's say patients scheduled for an elective procedure. And it was 3 weeks ago, right? We've been following them for 18 months. We tried whatever, right? Shoes, injection, oral therapies, whatever we did. They didn't get better. We scheduled them for surgery. And that was done 3 weeks ago. That's fair, right? How long does it take you to get somebody on the OR schedule and make that all happen? It takes a couple of weeks, right? And then some of us have this pre-op visit where the patient comes in a day before or 2 days before. And what do we do there? We sign consent form, give them a boot, write for post-op meds, whatever you do, right? And the question is often asked, can I submit an E&M for that? Well, what's an evaluation of management? Let's define an evaluation of management. An evaluation of management requires a chief complaint. The patient comes in saying, this hurts, or this is a weird color, right? An evaluation of management requires a chief complaint, a history of present illness pertinent to that chief complaint, an exam that is pertinent to the chief complaint, and then some management of that chief complaint. We might not like this, but signing a consent form, writing a prescription, reminding them of instructions of a surgery that's already been planned is not an evaluation and management. If the patient comes in and says, I'm here to sign my forms and get my prescription, that is not a chief complaint. And I've seen these notes that fail. A lot of the work that I do is trying to defend our colleagues. These notes that say patient presents for a pre-op visit. Well, that's not a chief complaint, right? Now, on the other hand, if they have questions, if they forgot stuff, if they want to say, can you operate the other toe also while you're there, right? This happens. Now, that is an evaluation and management. So, and then I'll add one more thing, because I've had a lot of colleagues say, but my hospital requires that the H&P be performed within 1 week of the surgery. So if I scheduled it 3 weeks ago, because it takes them that long to get on the schedule, but then the hospital requires that the H&P be performed within 1 week, so I have to bring them back that week, shouldn't I get to submit for that? Well, H&P, think about what those letters stand for, does not equal E&M. H&P does not equal E&M. That's taking a history and performing a physical. There's no code for an H&P. It doesn't exist. That is not an evaluation and management, what we just described. So unfortunately, that pre-op visit is probably not something that we can submit. I promised that this would be fun and talking about stuff that we can do instead of stuff that we can't do, and I ended on a bummer of what we can't do. So let's conclude and surmise, getting back to the good stuff, a reminder that there are many situations where we can submit for the services that we perform during the postoperative global period. If it is an unrelated E&M, we can use the 24 modifier. If it is a related procedure, regardless of where we do it, we can use the 79. If it is, sorry, I said the wrong thing. If it is an or maybe I did say it right. I'm going to repeat it just in case. If it is an unrelated procedure, we can use the 79 modifier regardless of where. If it is a related procedure, we can use the 78 modifier if it's performed in an operating or procedure room. And if it is a stage, planned, or more extensive procedure or therapy, we can use the 58 modifier. Thanks for your attention, and we'll welcome back in Andrew and Michelle as moderators. Please put more questions in if you have them, and we'll go through this Q&A session together.
All right, Jeff. The first question is, if you have a hammer toe repair with percutaneous pins placed, the provider wants to bill 20670 in the office with modifier 58. Any suggestions to break the bad news that this is bundled? This person has a provider who doesn't want to hear it.
Yeah. So okay. So I'll repeat the question. Hammer toe repair with pins sticking out the tip of the toes, and the provider wants to submit coding for removal of the pins with the 58 modifier. We don't even have to get to the 58 modifier because this language is in Chapter 4 of the National Correct Coding Initiative Policy Manual. And the person who wrote the question, to their credit, said, any tips on how to break the bad news? Yes. The way to break the bad news is with a reference, not I heard or he said or on the webinar so-and-so thought, because that's not what determines any of this. I want to pull it up so bad, but I'm worried I'm going to mess up our thing here if I go to a different website, and I don't have the section memorized, but this is free and online. If you Google National Correct Coding Initiative Policy Manual, you'll see there's 13 chapters. Chapter 4 is the musculoskeletal section, and if you open up Chapter 4 and do a word search for removal, I bet that'll get it. Maybe fixation. Somewhere in there, it says something to the effect of superficial, or if it's just pulling a pin or something, we can't submit that. So you're right. And my tip for breaking the bad news is to provide the reference of Chapter 4 of the National Correct Coding Initiative Policy Manual.
Great. Next question, I believe you answered. Is it appropriate to bill an E&M code for pre-op visit 1 week before surgery, before the surgery is performed?
Oh, cool. All right. I'm glad I did it. I guess you're seeing, I'm not seeing.
I'm looking at the Q&A panel.
Oh, there was
You're
a
probably looking at
bunch
the
of
chat.
questions. Sorry. All right. I was looking in the wrong place.
But there's a follow-up to that one.
Yeah.
If we send a patient for an H&P for surgery to clear for cardiac or diabetic reasons, how is that different than our own H&P if we do it in the pre-op visit?
So I think the question pertained to submitting coding for that. There's also no code for that, right? There's no code for sending someone for an H&P.
I think the question is, why can the cardiologist or the internist bill for undoubtedly for the H&P and we can't?
They can't either. They can't either. We are playing by the same rules. None of this is like podiatry or the fact that we're specialists or we're being treated differently. They are playing by the same rules. And if the patient shows up and says, I'm having surgery and I need you to do an H&P, there's no code for that for them. And we don't hear about it a lot. And I'm not rooting for the bad guys by any means, but bad things do happen to other provider types. Not as frequently as you would expect. And again, I'm not rooting for the bad guys, but it happens. So they shouldn't be coding for that either. But how many times does patient get in front of their PCP and not complain about something, right? They can't even get to a visit with us without coming up with something. So I think most of the time they're going to say, since I'm here, and then they got their E&M. But if they just walk in and say, I'm having surgery, give me an H&P, and the doctor does an H&P and doesn't manage anything, there's no code for that. Now, if they are asked to clear the patient, which that is a different thing, now that changes the answer a bit. Now they're managing something.
Okay. Let's see what we got. Okay, I think this one's a little tongue-in-cheek. Can you stage a hammer toe repair? Tenotomy day 1, it wasn't enough. Next stage would be osteotomy of the toe.
I hope it was tongue-in-cheek. Oh, my gosh. Okay, so I'll repeat. We should make decisions on what is best for our patient only. We should make decisions that are evidence-based. We should make decisions based on peer-reviewed literature. And I am not aware of any peer-reviewed literature that suggests that's an appropriate way to fix a crooked toe. We were all trained on sequential reduction and do this first, then that, then that, then that. And any literature textbook that exists suggests that that's the right way to do it. Michelle, you are more well-read than I and more of a academia person than I am. Do you agree with that guidance?
100%, yes. Okay. Yes, and unless for some reason this is a patient, I do little tenotomies in the office sometimes for those distal ulcerations or calluses. And so I'll tell the patient then, we'll try this first, especially if they're a high-risk patient. And then if this doesn't work, we can do a full hammer toe repair. So I have done that before. So I think as long as that's documented and, you're trying the simpler thing first, it fails, and then you can go do the whole hammer toe. Maybe that's what they were asking.
Awesome. I think that's a great example of what they were asking. And that second one that you described would be more extensive. I think that's a great example. Maybe that's what the person was getting at.
That makes more sense. Okay, next question is, how do you get paid for x-rays 2 weeks post-op in the office? Is there any modifier needed?
No modifier needed. Radiology does not fall into the global period. Just submit the x-rays like you would normal.
Okay, next question. What happens if you meet with a patient and during that visit you discuss a treatment plan that includes surgery as an option, but the patient was going to think about it? Patient calls the office unbeknownst to the doctor, and the patient is then scheduled for a pre-op visit to discuss the procedure and sign a consent form. Would this qualify for an E&M since the doctor really did not discuss in detail the procedure?
So it depends on what is performed and what is documented. If what actually happens and what you document is what's written here, right? Patient called the office and said they want it done, and they came in today and we signed a consent form, then the answer is no. But I think that would be extraordinarily rare, right? I think most surgeons would want to have a conversation with the patient after they make the decision, right? Like, okay, now we're doing this. Here's what needs to happen, right? This is what to prepare for. This is what to expect. This is what your restrictions will be after. And you may have had that conversation during the period of time that they were still considering it or thinking about it or talking to a family member. So on the other hand, if you document, since patient was last here, they decided they wanted to do this. Therefore, today it was medically necessary to have the following discussion and then go through, right? Advantages, disadvantages, risks, complications, recovery period, what to expect. Now we got an E&M. So it depends on what is performed and documented. I think most of us that are surgeons are having that conversation.
Right. Next question. In your in the hold on, I just lost it. Okay. How do I get paid on a new patient who presents with an ingrown nail? We discuss options, do an exam, do 11750. I want to get paid for the initial office visit and the procedure.
Okay, so this is a whole other thing now, right? This is a different topic, which is not really what we talked about here. But let's do it. This question deals with what is the hottest topic in all of coding, not just for podiatry, across all specialties, the significant and separately identifiable evaluation and management. This is a new patient, first visit, that had a procedure done, a medically necessary matrixectomy. When we submit both an evaluation and management and a procedure, including on a new patient, the evaluation and management must be significant and separately identifiable from the procedure, which means, those are just a bunch of words, which means we have two separate services, one of which is an E&M and one of which is a procedure. And here are the magic words: with no overlap in the work associated with the E&M and the work associated with the procedure. So in this example, the work of the E&M is the M, is the management, right? Something along the lines of, this patient has an ingrown toenail, right? This is what's documented, right? Doesn't have to be exactly this, but I think this models an E&M whose work sees no overlap with the work of the matrixectomy procedure. I explained ingrown toenail to the patient. We discussed the fact that this has been a chronic condition. We discussed what may have caused this and what the patient can try to do to prevent this from happening in other borders in the future. We discussed different treatment options, which include this, and this. You might know they need a matrixectomy, but there's other options, right? We discussed advantages and disadvantages of these treatment options. We discussed potential risks and complications of these different treatment options. And patient was interested in matrixectomy, and they asked if we do that today, how long it could be before they're able to bicycle again, whatever, right? That's the work of the E&M. And then I suggest a paragraph, no rule that says you need it. I suggest then a separate paragraph explaining the procedure. And I suspect some of you have heard me say this before. In my office, and this is not a rule, I'm just sharing what I do, the last sentence of that first paragraph is, this evaluation and management was significant and separately identifiable from the procedure described in the following paragraph. And that, I think, constitutes an E&M and a 11750. There's no such thing as an office visit. It doesn't exist. And the more of us that can get that out of our vocabulary, the better. I think it leads to a lot of errors in coding. It leads, I think, some to think, well, if the patient walked in the office, that's a visit. That pre-op thing that we talked about, right? Isn't that a visit? There's no code for a visit. It doesn't exist. It's an evaluation and management.
All right. Next question. In your in the example you gave of the unexpected DHIS TMA, is dispensing a wound care product wrapped into the global also, such as collagen powder, etc.?
No, it is not. So you may be familiar with the surgical dressings available through Taylor Medical, things like collagen powder that we can stock, right, in our offices and then dispense. And there are profits, crazy profits, associated with those surgical dressings like collagen powder. Those are not included in the global period. So yes, we can dispense those, not included in the global.
Patient has surgery for a hammer toe and then develops a new problem unrelated to surgery under the global. How are you able to get paid for this new E&M even though they're under a global for something else?
Please tell me you weren't here for the first 12 minutes.
I think the person said, sorry if I missed this.
No worries.
So
we can do it quickly. This is recorded. Michelle shared at the beginning how to access that recording. So there's a much more thorough, better answer at the beginning. But very quickly, an unrelated E&M during the postoperative global period can be submitted with a 24 modifier. So in your situation, diagnosis hammer toe, probably a secondary of pain, pointing to the E&M with a 24 modifier. We're just teasing. Evaluation and management code with the 24 modifier indicates this E&M is unrelated to the problem for which the patient is in the global period.
Okay. Next, patient has an ankle fracture and is in a splint and is following up under the global period. If we take off their splint and review x-rays from another facility and reapply the splint, how would this be coded? Versus coding for a left ankle fracture and then wanting to dispense a cam boot, what modifier would you need to add? It's a lot there.
Okay, so I think it's two different things.
Two different questions.
All right, so ankle fracture in a splint in the global period. We take off the splint and put it back on. No code for that. Review x-rays from another facility. There's no coding there. So here's the problem. There's no double dipping on the professional component of the x-ray. And chances are excellent if they're walking in with a disc because they had the x-ray done somewhere else, somebody has done the read, right? The radiologist generated a report, which is probably terrible and useless and doesn't help you in any way. And you have to put in the disc and look at the images anyway. Unfortunately, if the radiologist got paid for the read, we can't. So I don't think there's any coding for that. And then the second part, ankle fracture. Okay, and then dispensing DME, also available through Taylor Medical. What modifier do you need on the DME? None. No modifiers are needed on DME. So a cast walker during the postoperative global period does not require any type of modifier.
Here's another question, I think, under the other category. I don't think we asked it. How do you code a debridement of an ulcer that develops on the incision post-bunionectomy?
Yeah, I messed up by telling people to go to the chat. Sorry, I shouldn't have said that.
Oh, that's fine.
Apologies. So we covered this with the 78 and 79, right? So I'll do it more quickly. If you want a more thorough explanation, this was recorded. So patient has a bunionectomy procedure, it dehisces open, and a debridement is performed. So what is that? That is a related procedure which is the 78 modifier, which requires that that be performed in an operating or procedure room. So if it was not staged and it's just a related procedure in the office, we can't submit for that. That's just part of being a surgeon. If it is performed in an operating or procedure room and it was medically necessary to do so, then we can submit that debridement with a 78 modifier.
All right. I think that's it for the questions. All right, Jeff, Dr. Lehrman, thank you very much for a fantastic presentation. Thanks for everyone for being here and participating and asking great questions. Their next Taylor Tuesday is going to be on Tuesday, August 2nd, at the same time, 8 Eastern, 5 Pacific. The presenter is Dr. Patrick McEnany, and his topic is Tips for a Successful Office. So we will see you on the next Taylor Tuesday.
Great. Thanks, Jeff. Thanks, Andrew. Thanks, everyone, for attending. Just remember, you can look at all these lectures up on our website. All right. Thanks. Good night, everyone.
Good night.
Good night.